Hello everyone. As Victoria says, I'm Director of the National Centre for Creative Health, and we are working in partnership with NHS England in a variety of ways, but primarily around attempts to embed creative health in systems, i.e. integrated care systems, at a systems, place and neighbourhood level. But today we're going to particularly focus on health inequalities. So just a quick update on what we're doing in the centre. So we have what we call our creative health hubs, and that is this partnership which Naomi and Jane are part of. And in 2021 to 22, we worked with 4 integrated care systems: Gloucestershire, Shropshire, Telford and Wrekin, Suffolk and North East Essex and West Yorkshire, to really learn about what they were doing as systems to embed creative health in varying degrees, because they're in varying degrees of maturity, if you want to call it that. And that learning has then informed a toolkit, which also includes various examples from elsewhere in the country. Predominantly the illustrative examples are from those 4 systems. And the toolkit, which we hope will be published in January, is based on a sort of structure that is similar to other NHS England toolkits and their maturity framework for social prescribing. So it covers the domains of leadership and strategy, planning and commissioning, workforce development, digital and evidence. And then this year, we are working with NHS regional personalised care teams, and actually more and more with individual integrated care systems, to look at how we can spread the learning from that first year. And then in partnership with UKRI, and particularly Arts and Humanities Research Council, we're working on this mobilising community assets to tackle health disparities, now called health inequalities again. And in 21 to 22, 12 research programmes across the UK were funded and still doing their work. Then recently 16 community research consortia have been funded, and they're just starting now. And there's a lived experience advisory group who've helped with the process of selecting those research consortia, which are university led. We've been involved in supporting that aspect of it, and then this will lead towards a 20 million research fund in 2023 to 26. And in fact, Hannah Waterson is here in the group, and she is our research and policy manager at National Centre, and I can see she's oh, maybe it's not that Hannah, another Hannah has written something in the chat. Hannah is much more knowledgeable about this programme than me, if anyone wants to find out more about it. Okay, next slide. Now, creative health as a sort of umbrella term may be something you like or you don't like. We're using it. Obviously, the centre is called the Centre for Creative Health, and it came out of the Creative Health Report. We have found over the last few years that health responds quite well to this name. They don't seem to sort of object to it. And there was a move in the sector to move away from arts and health, because arts didn't really seem to cover culture more broadly, museums, etc. So anyway, it's what we use, but it's not to say that all of you should feel obliged to use it. And we've defined creative health in this way. So we're covering both the activities, the interventions, if you like, and the breadth of what you might call the territory outside the arts does move into creative activities in nature, such as gardening and cooking. I don't know you don't cook in nature, but you know what I mean. So slightly outside the usual boundaries of the arts. In fact, I was in a meeting earlier where we were discussing bricklaying and whether that classed as a creative activity. So bit baggy, amorphous. And then this idea of approaches, which is that we particularly in our work are very interested in creative approaches to change within health systems. So that doesn't necessarily involve activities or interventions, and maybe around services, co-production, education, workforce development, that kind of thing. And then just that other lower statement to remember that this can happen in all sorts of different places. Okay, so next slide. I think maybe that's the last of my slides. No, am I doing this one? Yeah, so just thinking about the role of creative health, it's right across the life course, that it can cover everything from prevention, treatment, recovery, management and promotion. I'm sure you all know that. that we do believe there's an offer that an alternative non-clinical approach can make to health and social care in the context of massive challenges. Creative health can also provide that vehicle for engaging with communities, with people who don't necessarily get their voice heard, and it can complement medical pathways. So it can be in care pathways, it can be more medicalized if you like, but it can complement a more medical offer. So I think that's all I'll say. Naomi, is that okay?
So I'm going to pick it up now. So yes, I know some, but not all of you. I've been living and working as a GP in Shropshire for the last quarter of a century now, and increasingly got interested in the non-clinical approaches to health and wellbeing, and in particularly creativity. Music's my thing, so that's what brought me into my interest. But now my current role, I don't actually work for NHS England as such, but this programme is supported financially by NHS England. So Naomi and I have got some time funded to work with Alex, Hannah and others in the Centre for Creative Health in this sort of spread and scale of how we try and embed creative health and all the facets of that, as Alex has just outlined, in our integrated care systems. So I was just going to give you a little bit of lowdown of what integrated care systems are or are supposed to be. I hope this, I mean, it won't be, it's not in any depth. I'm very happy to answer any more detailed questions, but it's just an overview on the assumption that most of us, and even those of us right in the middle of an integrated care system, in Shropshire, I'm the clinical lead for personalised care, which clearly includes lots of creative opportunities. But there's sort of an assumption that ICSs are here and they're sorted and they've been singing and dancing since July, and it's not how it feels. So it may well be that you're coming across quite frustrating conversations about sort of people not thinking up and thinking in a very joined up way, or not knowing how to find people. And basically, because what I'm explaining now it's sort of theoretically there, but realistically things aren't very well embedded. But the purpose of an integrated care system is to achieve these four aims. So there's an improvement. The first one we wouldn't be surprised about, improving health outcomes at a population health level, so not so equitably across, based on the needs of the population. And therefore that leads nicely into the fact of understanding and tackling health inequalities. There is clearly something around the best use of the public purse that's been spent on health and care. And then we are actually now tied into supporting broader social and economic development, and that includes around climate. So it's a really broad remit for health and care systems beyond what we've had before. And the idea being that we are working much more closely with our local government and our communities, rather than a sort of, as traditionally has happened, sort of the health service getting on with things and so-called in partnership, but not in as meaningful a way as could be. So those are the four aims. If we go on to the next one. Okay, so this is a bit overwhelming. I had a little look. I was trying to find a simple diagram to demonstrate what an ICS is. And this was as good as I could get. The King's Fund are pretty good at these things, actually. But so I just thought it might, and apologies if you've got all this worked out, but sometimes I think it's difficult, even when, as I say, we're in conversations locally, to work out what the difference is between some of these bits and pieces. So NHS England manages the performance and supports the NHS. It certainly feels more like the former than the latter when you're in a system. And there's a huge change going on with NHS England, because the national regional teams are all having a reorganisation so that they're fitter for purpose to support this new system of ICSs. There are 42, by the way, across England. There are 42 ICSs. And they're geographically, there's a lovely map that we could share if you'd like, but there's 7 regions, and within the 7 regions there's 42. The Care Quality Commission, that you'll all be aware of, independently, it's an arm's length body, and it independently reviews and supports to some degree the different parts of the health system. health and care system, sorry. So the statutory bodies, so we've just moved from a system of having clinical commissioning groups, so CCGs, and they were the statutory bodies, and the other range of statutory bodies in the NHS are the provider trusts. So you've got mental health trusts, acute trusts, community trusts, and various others. But they're the statutory bodies. And the only statutory features that are new are that the clinical commissioning groups have gone, and we have two things: an integrated care board and an integrated care partnership. And I'm going to start with the integrated care partnership, although quite often in conversations you'll find people starting with the integrated care board, which is a much more health focused way of looking at things, I would say. So the integrated care partnership, if you imagine we start with our communities and the local authorities and the wider population that we're serving, and they have the all the data around health inequalities through joint strategic needs assessments. There's the partnership with all the different organisations within the local authorities and in our communities that deal with the wider determinants of health. And they need to, and they have, through what's called health and wellbeing boards, been agreeing strategies for each local authority. But for example, in Shropshire, we have 2 local authorities, and therefore we have to have a way of having an integrated care partnership, which brings together the thinking and the data and the needs of 2 very different local authorities into an integrated care partnership, and comes up with a strategy for our ICS. So that's no mean feat. The other statutory board, function, which is talked about much more, is the ICB. And the way I'm looking at it is the Integrated Care Board, which has a membership outlined here. So you've got independence, rather like any board with a non-executive and executive membership, but also the difference here between the CCGs, you've got the chief execs and chairs from the provider organisation. So you can begin to see quite a lot of argy-bargy really happening, because you've got those setting the agenda and those delivering. And what you'll see is not here at all. So although there is a requirement for everybody to work in an integrated way, that isn't statutorily enabled by the law. Just going to pause there a moment. So essentially, we've got the broader strategy agreed by the ICP, and then the ICB are required to deliver that. And they need to deliver it through the bits at the bottom. They deliver it through partnerships and integration. But as I've said, there is no, for example, it's quite difficult, although the providers are all supposed to be working together and delivering this strategy. That's very different from previously, where if you can imagine some of the really big acute trusts where you live are sort of suddenly being told they need to deliver a strategy that meets the needs of the whole community, whereas they're very used to just dealing with the patients that come into their front door. And quite rightly, the meeting the clinical and care needs that they know about, whereas actually now we're looking at a much broader version of health and care, and looking at the preventative and upstream approaches rather than just dealing with the patients and clients coming in the front door. So I won't go into any much more detail about that, but the idea is that providers work together somehow through some form of governance, that we've still got the health and wellbeing boards that have to work together, as I've mentioned. And then within that, the term community and place and neighbourhoods is bandied about a lot. So we've got 42 geographies. Within that, there are places that tend to be sort of a local authority. In most cases, each local authority is called a place. But if you think about where you're living, your local authority isn't one type of population. Within each local authority, there's a huge variety of communities, parts of communities' needs. So that's where we're looking at breaking down into sort of wards, neighbourhoods. There'll be all sorts of boroughs and all sorts of different terms used for that, to look at place-based approaches. So you might have an overall part of your integrated care strategy, but that it's delivered at place to make most sense for the community living in that place. And within places, you've got neighbourhoods, which will be even smaller, and then the GP practices are working together in primary care networks to deliver some services and to bring in lots of extra roles to support general practice. But the primary care networks aren't responsible for everything else GPs do. So there's quite a lot of development in how GPs can work together where it makes sense, but still deliver core general practice as needed. So apologies, that's a bit of a heavy slide, and I'm really happy to discuss it, or we can come back to that later. The next one is where this is my attempt at explaining what personalised care means. And I think Alex said creative health may or may not be appealing as a term. And in the same way, personalised care produces pretty strong responses. A lot of clinicians are sort of, well, hang on, of course we do personalised care, but then when you really look into it, we have to question whether that is the case. And also it's being understood in a lot of different ways. Essentially, there is an NHS England has produced a framework or a model, which it's called personalised care, and it's this pyramid essentially, where there are 6 components, and that the whole population should be able to have access to shared decision-making discussions and a choice of how they are managed, underpinned by access to all sorts of resources in the community, clearly including creative health and including, but not only, social prescribing. Then the next level for people with more longer term conditions and other a range of either physical or mental health conditions, it is of benefit to also, in order to support their self-management, to have support and care planning. And then for those with the most complex needs, the options of actually taking their own health or health and care budgets to use according to their needs. And this is all about empowerment and agency. And you could imagine in each of these 6 components, there are loads of opportunities for creative health. What I'm trying to demonstrate on this slide is that if you're trying to work out how with your organisations you might be able to get into this game and see how creative health and your offer can help with the development of the and delivery of our integrated care strategies, then a good place to start is to understand where the health inequalities are, where the options for prevention are, and using the population health data. And in the middle, the sort of sweet spot in the middle of that is often where we could have most impact applying personalised care, and therefore any opportunities to get in there. On the right, I'm sort of proposing really that if we can identify some of the things that will make most difference. So, for example, we might find children with mental health problems or adults with long-term conditions. Then we can actually help and shape the priorities that the ICB that you're trying to work with have. And also the added bonus, and I think it's one of the earlier slides, is that we can demonstrate through this personalised approach how we can have work together and co-create with our communities the solution. You'll be doing that all the time at different scales. And this is just looking at a slightly larger scale at an ICB. And that will deliver the aims. And of course, we always need a hook, don't we, as to how we can get in there and get the ears of people in this new leadership system. And health inequalities being one of the aims. There's lots of opportunities for us to discuss today how we can do that. So I think that's the last one of mine. Over to you now.
Great, thank you very much. So this is a really busy slide, I'm sorry, and as James already suggested, the King's Fund is a wonderful place for really kind of rich and well explained information actually, and I would recommend anyone have a bit of a deep dive in there. So hopefully this won't be death by PowerPoint, but I think just to kind of put in context when we're talking about health inequalities, what we are talking about, and I think the term gets used so broadly, but I suppose very concisely put, health inequalities are the unfair and avoidable differences in health across populations, and that you're looking at health outcomes and access to health. And I think this is sometimes where we can even ourselves get a bit trip ourselves up when we're talking about health inequalities. So we use the term to refer to the differences in care that people receive, but also the opportunities they have to lead healthy lives. And this is where we talk about the kind of wider determinants of health and the things that influence health. But when you talk about health inequalities, obviously health inequalities are experienced by different people from different places, and mostly have been measured by the health outcomes of different groups. And I think probably the one, for the most part, that is really used is looking at life expectancy, the life expectancy of people, not just the life expectancy and how long they live, but how long they live healthy lives for. And mostly that will relate back to their access to care, the quality of care that they receive, but really importantly, the kind of socioeconomic factors that influence their well-being and their life. So it is looking at the health inequalities of what and then between who. And sometimes that's difficult to separate, but for me, when I understood that bit, it became easier for me to then understand what contributed to that. So and hopefully these kind of two infographics will make what I'm explaining a little bit more kind of understandable. But there are so many things that impact on health inequalities. And I think most importantly, they really are influenced by the wider determinants of health. And those wider determinants being the things like income and housing, education, work, transport, and the environment. And then our health related behaviors and lifestyles, so things like exercise, smoking, diet, all of the things, alcohol, drug taking, all of the things that impact on our health outcomes. And then obviously the places that we live in, the places we live and the communities we live within. We could live in people can live in quite rural communities that are good for their well-being, but then that rurality can also influence some not so positive outcomes for their well-being, because it could influence their access, how they access healthcare, or how they access their connection with other people and their environment. And then around that as well is our kind of integrated care and health and care system, which Jane has just been talking about. So when we put all of those things together, they are really the things that influence the health equity or health inequality that we experience. And I suppose, well, hopefully what that demonstrates is that if you look at health inequalities and you think about how, from a creative health perspective, we can take a preventative approach, there are so many opportunities that sit naturally within the place that we live, within our communities and the choices that we make. But also how we use creativity to help influence and help our communities and the people who, as Alex spoke about earlier, that the people who don't often have a voice, so those people who are living in areas of abject poverty, who may find it difficult to articulate how they feel and what they need in order to keep them well, using creative health approaches to help give people a voice and to articulate those needs and those wants are incredibly impactful. And interesting, I only shared this morning a podcast I've been listening to, I've been kind of delving into, and there's a wonderful example of a piece of work called Creative Insights that was working with a group of young people in Leeds and in Glasgow, where creativity and creative approaches were used to help young people understand health inequalities, but also how they could influence and determine change within those. So the second infographic on this slide is I suppose that idea of like what is it that makes us healthy, and it talks to just what I've explained, that all of these things, it's multi-layered really, and ultimately what we are looking at is how we can influence better health outcomes for people at a population health basis, and that population may be nationally, it could be within our integrated care systems, so as a whole, right down to that kind of neighbourhood and community level, and what is important to people within those communities that give them access to more equitable healthcare, but also lifestyle choices that influence their health outcomes. So the NHS's approach to tackling inequalities is what some of you may be very familiar with, others may not, but it's the Core 20+5. And I think for the most part, actually, this infographic explains it quite well, but what it breaks it up into is it is a national approach to tackling inequalities from an NHS perspective. And each ICS is looking at, has a plan around their Core 20+5, but also is looking to their JSNA, so the Joint Strategic Needs Assessment, and the outcomes and the priorities of their area to really influence where they prioritise the work. And I think this is the hook. The hook is understanding the local landscape. The hook is understanding what the needs are for the communities, the neighbourhoods, the places, the systems that you are working within. And the data that influences that is really the key to understanding and unlocking some doors in terms of opportunity. Interestingly, only last week, the NHS has also just released a Core 20+5 approach for children and young people as well, and I can share that with Victoria to share with everyone after if people would like access to the presentation. But I mean, obviously everyone can see this, but it is really that Core 20 is the kind of most deprived, the 20% most deprived of the kind of population, and then that target group of people in terms of that the population groups that experience poorer than average health access, and that will depend on area, but then those key clinical areas of health inequalities, and within those, if you think about severe mental illness or early cancer diagnosis as two examples, there's so much preventative work that goes into those. So yes, there is a focus on the acute managing people to live well and live better, but also what's happening around that prevention element as well. Hopefully some of that has made sense, but I'm more than happy to answer or take or field any questions in relation to that. But I think what we are hopefully, or what I'm hopefully articulating really, is the kind of need to harness the knowledge and the information around how systems are looking at improving not just healthcare, but that health inequality, and how we can identify opportunities to support that in its creation, but also in its kind of prevention at a level where we're working with people. As Alex mentioned, part of the work that I've been involved with over the last 18 months, I think it is now, is the development of the Creative Health Toolkit. And what we've done is we've just taken a bit of a snapshot here so you can get a bit of a feel, a bit of an inside look into what this might look like. And what we have done is we've had a great opportunity to work with 4 areas, broadly 4 areas, at differing stages in relation to how their creative health offer is emerging. So some quite advanced, some not so much. And we've kind of been on that journey with them. And because of that, have been able to really gather some really rich insight and experience of how people have, or how areas, systems, organizations have approached their creation of their creative health offer in different areas. But one of the areas of the toolkit is obviously leaning into health inequalities and firstly what it means, but also how we can help with how creative health can help address health inequalities, not only in that kind of education and understanding, but actually working at a kind of a prevention or helping people living with some of the challenges that they have. So there is definitely for us something about understanding more about your experiences as well, because, you know, we would like to keep feeding into this toolkit and getting more examples and experiences to share, so we can kind of keep the learning going in relation to the whole area of, obviously, of creative health, but in relation to health inequalities most specifically.